Why is healthcare so expensive in America? In this show, we've talked about pharmaceutical companies and health insurance abuses. But today, we're tackling something we haven't talked about yet. Hospital mergers are driving up your healthcare bills, and the data proves it. In this episode of Care Talk, Natasha Murphy from the Center for American Progress breaks down how hospital consolidation hands big hospital the power to charge you whatever they want. Welcome to Care Talk Live, a weekly American healthcare policy show and podcast where we explain how healthcare works or doesn't work and get you answers. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Be sure to subscribe to my channel or podcasts wherever you get your podcasts to get future Care Talk shows. When hospitals merge, competition disappears. And without competition, there's no check on prices. Studies show hospital consolidation raises costs by 20 to 30% or more, but behind those numbers are real patients, real families, and real medical debt. This is a David versus Goliath story, and you need to know which side you're on. So, welcome to Natasha Murphy, the Director of Health Policy at the Center for American Progress.
Hi, Laura. Thanks so much for having me back. It's always a pleasure.
Well, thanks for being here. And let's start with most people have a negative opinion of insurance companies, and they're pretty skeptical of big pharma and outrageous drug prices. But people generally tend to have a positive feeling about their own hospitals. Let's talk about the systemic problems of why hospitals merging together are hurting patients.
Yeah, absolutely, Laura. And I completely agree that oftentimes hospitals are kind of serving as the elephant in the room as we seek to understand what's driving up the cost of care here in the US. So I think one of the most important things I would underscore for your listeners is the fact that, Americans are largely not, we're not spending more because we get more care. It's just we are simply paying more for the care that we do get. And a huge reason behind that is the fact that in healthcare markets across the country, we have seen those markets consolidate over the past really, 10 to 20 years. We've seen hospital systems acquire smaller provider practices and become these giant behemoth institutions that really leverage their outsized market power to drive prices up. And as a result, patients, employers, employees, and communities have fewer choices than ever before. And so generally, I think, kind of economics 101 is just the concept that, let's say there are originally 4 hospitals that are competing for patients and contracts. Insurers can negotiate with those 4 hospitals. But if over time, hospital A acquires B, C, and eventually D, we are left with one dominant system in a community. And that they will control the bulk of the market or sometimes all of the market, and they have a disproportionate amount of leverage. And so in response, that hospital can demand higher reimbursement rates from insurance companies to ensure that they are actually in the insurer's network. And eventually those higher costs, they trickle down directly to employers and patients in the forms of both high premiums as well as high deductibles and other out-of-pocket costs. And so across the country, we are seeing, the vast majority of healthcare and particularly hospital markets are already incredibly consolidated. And so definitely, hospitals are a significant, and their high prices are a significant driver behind the overall high costs of care.
So let's talk about something that people may be especially upset about, including me. Facility fees, where you get the same exact care at a hospital versus a freestanding clinic or your local doctor, from labs to anything else, and they tack on an additional charge just because you're in a hospital.
Yes, Laura, that is a huge point of friction. And then honestly, oftentimes these huge unexpected expense for patients. I know myself personally, I encountered this recently getting an iron infusion. I went in, paid my copay, and then, 3 weeks later, I get a notification from the hospital system saying I'm staring down a $200 facility fee that, I had no clue. I thought that I had already satisfied, my kind of financial contribution and requirement. But because because the oncology fee or service was located inside a hospital, I got hit with that facility fee. And it is just an additional area that is eroding affordability for Americans with health insurance coverage. It becomes, just another kind of nickel and dime moment where folks already feel like it's hard for them to use their insurance because they're paying so much in premiums. And now, they face additional and oftentimes unexpected charges, all because, hospitals are seeking to recapture some additional funds.
Exactly. When I was visiting my oncologist in Denver at the UC Health system, I would get a bill from the UC Health doctors. I would get a bill from the facility itself. And what I ended up having to do was I would get my labs done not at the facility with the doctors, but I would get my labs done a few days before and hope that the labs got transferred over. But you shouldn't have to jump through all of these hoops just to avoid all of these nuisance fees that hospitals are tacking on.
Completely agree, Laura. I think, there's already there's so much burden in the healthcare system that forces patients, in addition to having to navigate their healthcare needs, to deal with whether it's paperwork or, kind of these additional surprise bills. It's just one additional example of how the US healthcare system is not working for the vast majority of Americans.
So hospitals would say, well, we need all this money to pay for our buildings and provide your care. What would you say to that?
Yeah, so I have heard many of those similar talking points, and I would be clear: hospitals are incredibly important anchor institutions, of course, as it relates to healthcare. They are open 24/7, there with providers to serve their communities, and oftentimes are huge economic drivers, particularly in rural areas. However, the reality is that there are so many hospitals across the spectrum. So whether they're nonprofit or for-profit hospitals that are really not living up to their end of kind of the financial bargain. So while they may be there to serve their communities, there is certainly incredible opportunity for them to show up, kind of much better fiscally. There's examples of, nonprofit hospitals continually acting like their for-profit counterparts. So whether that means their executive compensation is extreme, or if instead of providing an actual benefit to the community, they use that to create, kind of fancy art wings. And so one thing that CAP has long called for in the policy space is for nonprofit hospitals to really have an even higher standard to ensure that the community benefits that they're providing are actually benefiting the community in a real and tangible way. So whether that means providing additional uncompensated care or making sure that they're connecting patients with financial assistance resources to ensure that, one hospital visit doesn't turn into a massive snowball of medical debt.
Exactly. And I think that community benefits piece is really important because the reason why a nonprofit hospital has the nonprofit designation is because they're supposed to be providing something of value to the community for that tax break. And how they actually describe and handle that on their books. I read an article a while ago about, I think it was the University of Virginia hospital system was going after patients in driving them into medical bankruptcy and disregarding whether they should even have qualified for free or reduced services. So that's not really a community benefit.
Far from it.
So you mentioned more regulation of hospitals. What all should we be doing to make hospitals live up to their missions and serve the community, not themselves?
Yeah, so another policy option that CAP has floated and kind of others in the field actually would be a reimbursement and kind of price caps for hospitals, particularly those that are in these already concentrated markets. Recognizing that you have hospitals in certain locales that are charging somewhere between 2 to 4 times what Medicare reimburses for the same service in the commercial market. And so the notion of, regulators really identifying kind of the appropriate sweet spot to ensure that hospitals are not charging egregious prices that are then kind of being trickled back down to consumers. And one thing, the latest cap proposal is acknowledging that it's not oftentimes enough just to cap the prices. It's also really important to include in legislation or regulation a requirement and a mechanism for insurers to actually take those savings that they would be getting from price caps and reinvesting them back into their enrollee base and enrollee population. So to ensure that those savings are actually felt by the policyholders every month.
Absolutely. And also, I think we need robust mechanisms to look at the hospital consolidation. I know in California, their attorney general, when he was serving as attorney general, Javier Becerra, was really going after some of the hospital, some large hospital systems that wanted to merge in Northern California, which would have resulted, of course, in higher prices for patients, which is why they were looking at that. So we need aggressive action on the state and federal level to make sure these giant mega mergers of hospitals are stopped. And we need to look at what we do about the existing hospital mergers, like in Pennsylvania, which is a very consolidated state. Patients have been speaking out for years about how, the hospital consolidation is raising their insurance rates and reducing affordable care.
Yes, and you raised such an excellent point, Laura. The notion that as our regulators review some of these proposed mergers, where we find ourselves in the current state of healthcare markets and the broader landscape, it's not just enough for them to review the impact on competition. So while that is certainly important, I also think that it is equally as important for them to consider what impact will a merger have on overall healthcare affordability, acknowledging that the two are so closely intertwined. And oftentimes when you add that affordability metric, it will underscore oftentimes the reason why some of these mergers don't need to happen. So I think as we look to policymakers and regulators in the future, it's really critical that there be kind of a dual focus as they review and explore some of these proposed mergers.
Well, thank you very much for joining us, Natasha. And where can people find more information about the high cost of hospital mergers?
Yes, so they can visit the American Progress website, so that's americanprogress.org, and review some of the resources from Cap Health. We have, a wide array of research and policy recommendations on addressing hospital consolidation, as well as some of the other consolidation that's contributing to high healthcare costs.
Well, thanks again for joining us.
Always a pleasure. Thanks for having me.
And a reminder to everyone that we have free or low-cost healthcare resources available on our website at healthcarevoices.org/care talk. So check it out. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. And now our experts will answer your health insurance questions. So welcome to Louise Norris, Health Insurance and Healthcare Reform Analyst at healthinsurance.org, and Diane Archer, the founder and president of Just Care USA. So let's start with Louise, where there has been some action on Affordable Care Act health insurance from a judge.
Yes. So last summer, just like a week or so before the HR1, the One Big Beautiful Bill, was enacted, there was a what they called the Marketplace Integrity Rule that CMS finalized, and it had a bunch of changes related to health insurance marketplace coverage, including things like increased eligibility verification for special enrollment periods, increased income documentation, a shorter open enrollment period taking effect this fall, lots of things. A bunch of those provisions ended up getting stayed by a judge last August, so they did not take effect. They were supposed to take effect last fall, and they didn't because the judge stayed them pending the outcome of the case. So last Friday, the judge ruled and ended up vacating most of those provisions altogether, including like the increased income verification, the increased special enrollment period verification. One of the things the judge vacated was the shorter open enrollment period that is supposed to take effect this fall. Starting this fall, the rule called for open enrollment to end on December 15th in states that use healthcare.gov, and it prohibited state-run marketplaces from ending their open enrollment anytime after December 31st. So most of the state-run marketplaces had said that they were going to go ahead and go with December 31st as their deadline. Healthcare.gov was going to have a December 15th deadline. That has now been vacated by a judge. This could still be appealed by CMS, so nothing is solid yet, but just giving people a heads up that that's where we are right now. Also, just last month, CMS finalized a new rule that they do every year for 2027 marketplace coverage, and they included some of the things that they had already tried to do last year that had been stayed by the judge, including increased income documentation requirements and increased special enrollment period verification requirements. And very soon thereafter, the same plaintiffs filed another lawsuit. So we now have a ruling in the first lawsuit and a second lawsuit that was actually filed before that first lawsuit's ruling came out. So this is all very up in the air. So I would say the takeaway point right now is, although we've talked about a lot of the things that are in that 2027 rule that are coming for this fall's open enrollment, we could end up having another round of stays issued by a court, because this is being challenged in the courts yet again. So that's where we're at.
Thanks, Louise. And now a comment from Molly on Facebook. This is for Diane. My sister-in-law is on a UHC Medicare Advantage plan. We had to use an internal advocate to get some charges covered. They were billed identically to charges that were covered. As far as we can tell, they were just processed incorrectly internally. So Medicare Advantage charged some things that shouldn't have been charged. Diane?
Yeah. So sadly, Molly's story is all too common. Insurers offering Medicare Advantage plans just too often deny payment for services inappropriately. And that's because the less they pay, the more they profit. It's more money in their pockets. And they rarely face more than a slap on the wrist for routine inappropriate denials. So just the other day, the Office of the Inspector General released 2 new reports finding yet again that Medicare Advantage insurers very often inappropriately denied rehabilitation, nursing, and other post-acute services in order to maximize profits. And the reality, and the reason we know that a lot of these denials are inappropriate, is that when enrollees appeal, they win more than 80 or 90% of the time, even with the biggest insurers like United Healthcare and Humana and Aetna. The problem, though, is that most people don't know to appeal. They don't know that it's easy and that you don't need a lawyer and it costs nothing. But appeals do work in these situations. This all said, I am so glad that an internal advocate was able to help in this instance, because that's a much faster way to get something covered than an appeal, which often can take several weeks. And then the last point I want to make here is that if you were enrolled in traditional Medicare, which is not administered by a corporate health insurer, but rather directly by the federal government, there's no insurer middleman, then you would very likely get your care covered if your physician said that it was care that was medically necessary. There is no insurer that comes between you and your doctor, no insurer that second guesses your doctor. And so while Medicare Advantage insurers are required to cover the same benefits as traditional Medicare, what most people don't realize is that they can take a very narrow view about what benefits they should pay for. And as a result, Medicare Advantage plans tend to cover far fewer services than traditional Medicare covers. And so it's often a struggle, and I'm so sorry about that, but it's something that that people need to appreciate.
Thank you, Diane. And next, back to Louise. Can you talk about the latest proposed rules on Medicaid work requirements and what that means for patients?
Yes. So this is actually called an interim final rule. So it's different from the um, process where they propose a rule and then accept comments and then issue a final rule. This is essentially the final rule, but because it's an interim final rule, they're also accepting public comments on it. It is scheduled to take effect July 31st. So there's not going to be an additional final rule, but they could, based on comments and feedback that they get between now and July 31st, they could issue additional rulemaking. A lot of what it does is just clarify things that were really already laid out in HR1 in terms of who has to comply with this work requirement. Basically, it's the entire Medicaid expansion population, which is about 20 million people, unless you qualify for an exemption. And the exemptions had also been pretty clearly defined in HR1. Things like taking care of a child under the age of 13, being disabled. There are some things that qualify as exemptions. One of the things that they did lay out in this rule is clarifying what it means to have a medically frail exemption. You can't just have a medical condition that therefore gives you an exemption as being medically frail. The state will have to verify that the medical condition substantially impairs the person's ability to comply with the work requirement. So it won't be, there had been some advocates had assumed or thought that maybe CMS would just say, if you're on this list of medical conditions, that counts as medically frail and you're exempt. It won't be like that. So the state will have to document and verify that having a certain medical condition is actually impairing that person's ability to work. So it will be on a case-by-case basis. That was one of the big things that they clarified in this rule that we didn't have clarification on before. As far as complying, and this does take effect January 1 in most states. There are actually a few states that have already rolled out their Medicaid work requirements or will before the end of this year, but in most states this starts January 1. The entire Medicaid expansion population will have to have their eligibility rechecked twice a year starting in 2027, and CMS has confirmed in this rule that the state will have to verify that you're complying with the work requirement when you first enroll and then at every renewal. So basically every 6 months. States have the option to do more frequent verification. So some states might do it more often than every 6 months, confirming that you're complying. Compliance will be working 80 hours a month, volunteering or going to school 80 hours a month, and it can be like half-time student would count. You can also have a combination of like work and volunteer or going to school and working. Another thing that will count is earning at least $580 a month, because that's 80 times the federal minimum wage. So that can be earned income or unearned income, because it all counts as far as Medicaid is concerned. So they did confirm that in the final rule. So all states will be implementing this. States will vary in terms of how much automated data they have on hand. Just like we saw after the pandemic, when states started redetermining everybody's Medicaid eligibility, some states were able to automatically determine ongoing eligibility for a lot of their enrollees, and other states did not have much information on hand. So if you are enrolled in Medicaid expansion, meaning you're an adult under the age of 65 and you're covered because of your income, watch out for communications from your state Medicaid department. They will let you know if they don't have enough information on file to determine that you're in compliance with the work requirement. And if they need more information from you, they will ask for it. But if you don't see that notice, if you say you've moved and you haven't updated your address, or you just ignore the letter, your Medicaid will terminate. So it is really important. This was the same thing 3 years ago when states were redetermining eligibility for everyone. And back then what happened was the majority of people who lost their coverage, it was because the state couldn't confirm whether they were eligible or not. The same thing could certainly happen with this work requirement rule. So it's just really important for people to open their mail, make sure the state has their current address on file. If you don't understand something that's being asked for, make sure you reach out and call the Medicaid office and ask them what you need to do in order to be in compliance, because if you're not in compliance, or if they don't have enough information to confirm that you're complying, then you will lose your Medicaid starting in 2027.
Thank you, Louise. And we have a comment from, well, actually, this was a Reddit comment from Duff Forest Time, who says that I'm leaving my job and my new job does not offer vision insurance. I'm not buying it and paying the full premium prices. I feel like it's not really worth it since you're essentially prepaying for care. I don't mind going without vision insurance, but want to know if there's anything that's offered that's very low to no cost that offers discounted vision exams and glasses.
Yeah, so whether if once you leave a job and you're buying it on your own, you will pretty much find that whether it's a vision discount plan or a vision insurance plan, you are basically prepaying for care. The benefit that you get is largely offset by the premiums that you pay. So the more the plan costs, maybe the more of a benefit it will give you. If you get a really cheap discount plan, it maybe won't save you that much money, but it's not, it's not like health insurance where it's going to make a huge difference in terms of your ability to get care and how much it costs. This is anecdotal, but for myself, I wear glasses just to drive, and for years I have just bought my glasses online. I'm upfront with my eye doctor when I go in. I let them know I'm not going to be buying glasses in their office and that I just need the exam and the prescription. You do have to ask them, you may have to ask them to include your pupillary distance, the distance between your pupils, because I found that if I don't ask for that, it doesn't get written on the prescription, and you do need that in order to order glasses online. But I've been quite happy with it. I've ordered several pairs of glasses online. They are much, much less expensive than buying them in the eye doctor's office, and I have had zero issues with it, both prescription sunglasses and regular glasses.
Thank you, Louise. And thank you, everyone, for joining us to learn more about hospital consolidation and how it drives up healthcare prices for all of us, and answers to your questions on health insurance and healthcare. Be sure to check out more free or low-cost healthcare resources on our website at healthcarevoices.org/caretalk. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more, including we'll take another look at the medical frailty exemption and changes to Medicaid for next year, what you need to know and what you can do about it. So be sure to subscribe to my channel or podcast wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.